Hello everyone. Today we'll be talking about the evaluation and management of suspected ACS. By ACS I mean acute coronary syndrome. Now a few definitions that we'll go through before we start. ACS or acute coronary syndrome basically means myocardial ischemia or infarction, and there are various types. The first is STEMI, that is ST elevation MI, in which there is complete occlusion of the coronary artery due to plaque disruption. That leads to a myocardial infarction with elevated cardiac enzymes like troponins. And STEMI is a case that you have to consider for emergency PCI, that's percutaneous coronary intervention. The next type is NSTEMI or non-ST elevation MI, where the ECG may either be normal or they may show ST or T wave changes. In NSTEMI, the coronary artery is only partially occluded with a thrombus and the cardiac enzymes will be elevated. In these cases, usually we go for medical treatment, which is then later followed by PCI, usually after 24 hours. The third type is called unstable angina, which is basically similar to NSTEMI, but the cardiac enzymes will be normal in these patients. So coming to the immediate evaluation of a patient with acute chest pain. First thing we do is to take an ECG and then take a quick history and physical examination. In this, what we do is we have to try to find out about their chest pain. So if the chest pain is present, we ask about the characteristics, that is if it's anginal. Anginal pain is usually a crushing type of chest pain that's located in the mid-chest, usually associated with sweating, nausea and lightheadedness. It could be pleuritic or a pericardial pain, the pain of pericarditis, which is like a sharp pain that is exacerbated with inspiration, and pain from pericarditis reduces on leaning forward as well. The pain could be an acute, severe pain of an aortic dissection, which is sudden onset, severe stabbing pain in the chest radiating to the back or the interscapular region. Then we ask about exacerbating and relieving factors. For example, anginal pain worsens with activity and improves with rest, whereas if it's unstable angina, the pain will also be present at rest. And then we ask for associated features. For example, an MI will be associated with nausea, vomiting, sweating, and palpitations. Now, in a patient with angina, we have to suspect ACS if any of the following are present. If it's rest angina, that is angina that's present even with rest or very mild activity and lasting for more than 20 minutes. A new onset of angina which limits physical activity. An angina that is either increasing in severity or its frequency or the duration or occurring with less exertion than before. So in all these cases, you have to suspect an acute coronary syndrome. Then the next thing we do after we take the ECG, after we do history and physical examination, we go for laboratory tests. So the first is high sensitivity cardiac troponins and blood tests of serum creatinine, electrolytes, the complete blood count to check for hemoglobin, etc. Then we can also take a chest x-ray, mainly to rule out conditions like heart failure, which can lead to pulmonary edema, and aortic dissection, pneumonia. So to rule all of these out also, you can take a chest x-ray. Next is a risk assessment, which can be done using multiple scores like Heart score, Grace score, Compass MI, etc. In this video, I will be talking about the Heart score. So the HEART of heart stands for history, ECG, age, risk factors for atherosclerotic disease, and finally the troponin levels. Each of these have a score of 1, and a heart score of 0 to 3 is considered low risk, in which case you do not require any further management or further tests. If it is a heart score of 4 to 6, that is considered intermediate risk. And a heart score of 7 to 10 is considered high risk, and we have to immediately go for invasive strategies in these patients. Now, further steps in management. High-risk patients with elevated troponin levels. So we have done the initial history examination, laboratory tests, and risk stratification. Now, those patients who are considered high risk and with elevated troponin, as I've mentioned, we go for invasive testing directly. But for patients who have a normal first troponin levels and who are in the intermediate to high heart risk score category, in those patients we admit them and observe them, and we also send for a second troponin level after 3 hours. Now, if that second troponin level is elevated, then we can confirm that it's ACS and go for invasive testing. But if it's normal, you have to go for other non-invasive testing strategies like an ECG stress test, a pharmacologic stress test like dobutamine stress test, a stress echo, or a CT angiography can be considered. Now, what is the emergency department management for a patient with suspected ACS? We have to do a set of things as soon as possible, ideally within 10 minutes. First, take a 12 lead ECG. You want to know if it is an ST elevation MI, you want to know if there are any arrhythmias. Take their history of physical examination. Give them aspirin 325 mg to be chewed. Sublingual nitroglycerin can be given to relieve the chest pain every 5 minutes for a maximum of 3 doses, but it's important to note here that before we give sublingual nitrates, the patient must be questioned about the use of phosphodiesterase 5 inhibitors like sildenafil, because concurrent usage can lead to severe hypotension. Then nitrates have to be avoided in inferior wall MI with possible right ventricular infarction. So you can know this by seeing ST elevations in leads 2, 3 and AVF on ECG. Now, why should we be careful in these patients? It's because nitrates essentially reduce preload to the right ventricle, and an infarcted right ventricle will be unable to pump blood into the pulmonary circulation and then subsequently into the left ventricle. So these patients actually depend on the preload to maintain that cardiac output. So if you further reduce that preload by using nitrates, that will just worsen the cardiac output, leading to severe hypotension. Another important point is that many people may think that a relief of chest pain after administering nitroglycerin in the ED would most likely suggest a cardiac cause of chest pain like angina, but that's not entirely true, because a pain that happens due to esophageal spasm also can get relieved with nitrates. Next, give 80 milligrams of atorvastatin. Definitely important is to get an IV access. Collect blood for cardiac enzyme levels like troponins, complete blood counts, electrolytes, creatinine. Supplemental oxygen has to be given only if the SpO2 is less than 90%, not otherwise. And IV morphine is not routinely indicated, but it may be given only if there is persistent chest pain that's not relieved with any other therapies, or if the patient has an associated severe pulmonary edema, then you could consider morphine, but otherwise it's not routinely indicated. Now, when you look at the ECG, what are a few patterns that you can expect in ACS? So in a STEMI, you can expect ST elevation of more than 1 millimeter in leads, in all leads, except if you consider V2 to V3, the ST elevation should be more than 2 millimeters in men more than 40 years, more than 2.5 millimeter in men less than 40 years, and more than 1.5 millimeter in women. Also, if there is a new left bundle branch block, that could also suggest STEMI. For NSTEMI and unstable angina, you may essentially get a normal ECG, or you can see ST and T wave changes like ST depression that's more than 0.5 millimeter in 2 anatomically contiguous leads. You can see T wave inversions of more than 1 millimeter, again in 2 anatomically contiguous leads, and you can also see prominent R waves. Now, the next few slides will be focused on management of STEMI in particular. Now, a few terms that are related with reperfusion when you consider PCI. So, the first is primary PCI. This is PCI that is done emergently with the use of either a stent or a balloon to open up the occluded artery. This is the emergent PCI that is done right after the patient comes with a STEMI. The second is a primary PCI strategy. This essentially is emergent coronary angiography to detect the percentage of stenosis, and then that is followed by PCI if indicated. So if the stenosis is more than around 70%, then you could consider doing a PCI. But essentially this is a coronary angiography followed by PCI if needed. The third is a rescue PCI, which is an emergent PCI that is done if fibrinolysis has failed. The fourth is a routine early PCI strategy after fibrinolysis, that is, you do a coronary angiography followed by PCI if indicated. This is done between 2 and 24 hours after a successful fibrinolysis. And finally, the last point is pharmaco-invasive strategy. This is basically a combination. It's a combination of successful fibrinolysis followed by a routine PCI strategy, or it's a rescue PCI after a failed fibrinolysis. So essentially here you're combining the pharmacological strategy along with a PCI strategy. So these are a few important terms associated with reperfusion. Now this is a small flow chart about what to do when with a patient with STEMI. Suppose a patient comes with STEMI that is seen on ECG. You have to determine what the time to PCI could be. Suppose you are anticipating the time to PCI to be less than 120 minutes at that particular institution, then go ahead with primary PCI, and that has to be done within 60 minutes. But suppose the anticipated time to PCI is going to be more than 120 minutes, then you have to first go for the fibrinolysis strategy, where you give a bolus of fibrinolytic within 10 minutes. Then you immediately transfer the patient to a center with PCI. This transfer has to be done within 60 to 90 minutes. Then after reaching the center, you assess if reperfusion has been achieved with fibrinolysis or not. If it has not, that means it's a failed fibrinolysis, go for rescue PCI. If reperfusion has been achieved, then you can go for a routine PCI that can be done anywhere from 2 to 24 hours later. Next is pre-reperfusion pharmacology. What are the drugs that we give before we reperfuse the patient? First is dual antiplatelet therapy. So for patients who are going to be treated with fibrinolysis, we will go for aspirin and clopidogrel combination, 300 mg doses. And for patients who are going to be treated with primary PCI, then we prefer agents like ticagrelor, prasugrel, or clopidogrel. The second important is anticoagulation. For those patients who are treated with primary PCI, we'll go for unfractionated heparin. But if you're going to treat them with fibrinolytic therapy, then we can go ahead with enoxaparin, that's low molecular weight heparin, or fondaparinux. Now there are a few additional treatment modalities that we also give for patients. This will be different for different patients. For example, beta blockers we give for patients with a compensated heart failure, that is after they're stable, or a left ventricular ejection fraction that's less than 40%. We can also give beta blockers for patients who are going to undergo primary PCI but with their systolic blood pressure too high, that's more than 120 mm mercury. Again, these patients should not be in acute decompensated heart failure or with other contraindications like severe COPD, for example. Now, beta blockers have to be avoided in case of heart block or acute heart failure or severe hypotension. These three things are very important. The next is ACE inhibitors or ARBs. These are given for patients with heart failure or LV systolic dysfunction. Patients who have diabetes can also be given these agents. And these are usually started within the first 24 hours. And especially in heart failure, they are expected to have a good mortality reduction benefit. The next is the mineralocorticoid receptor antagonists like spironolactone. Now these are given for patients with heart failure or a left ventricular ejection fraction less than 40% who are not controlled on an ACE inhibitor or a beta blocker. Very important here, you have to watch for hyperkalemia. Fourth is the loop diuretics like furosemide. These are given for patients with acute heart failure and fluid overload leading to pulmonary edema. So basically you want decongestion. And finally, nitrates. Nitrates are given in patients with symptomatic heart failure with a systolic blood pressure that's less than 90 millimeter mercury. Again, nitrates help reduce preload to the heart and reduces the stress on a failing heart. So these are a few additional treatment modalities. The next thing is very important, arrhythmias and their management. Now, a very important effect of a myocardial infarction is risk for arrhythmias. So early reperfusion reduces the risk for fatal arrhythmias like ventricular tachycardia, ventricular fibrillation, because essentially these arrhythmias are caused because of a hypoxic focus. So suppose the patient has atrial fibrillation, we go for IV beta blockers for rate control. Again, you have to make sure the patient does not have acute heart failure or severe hypotension. You can try for IV amiodarone if the patient has heart failure, again, but the patient should not have hypotension. Immediate electrocardioversion can be considered in patients with hemodynamic instability, ongoing ischemia, and this is followed by IV amiodarone to reduce the risk of a recurrence of the atrial fibrillation. For ventricular arrhythmias, very important, early reperfusion is important because ischemia is what is precipitating the tachycardia. So you really require early reperfusion. Electrical cardioversion or defibrillation, IV beta blockers and IV amiodarone can be considered again for recurrent VT. And very important, you have to check for and correct electrolyte imbalances like hypokalemia, hypomagnesemia as well. Next type of arrhythmia that we can find is sinus bradycardia, atrioventricular blocks. For these, usually we see these with inferior wall MI because these are in the right coronary artery territory, and the right coronary artery also supplies the sinus node and the AV node. So inferior wall MIs are usually associated with bradycardia and blocks, and these usually resolve with revascularization. And in case of very severe hypotension, you could also consider IV atropine to increase the heart rate. Very important, you have to avoid agents that can worsen an AV block like beta blockers, calcium channel blockers, digoxin. All of these have to be stopped in such patients. So that was about the management of STEMI. Coming to the management of NSTEMI. Now the main difference, unlike in STEMI, there is actually no indication for an emergent fibrinolysis in patients with NSTEMI and unstable angina. So we directly go for pharmacologic management, which includes antiplatelet agents. That's the dual antiplatelet therapy with aspirin with either ticagrelor, prasugrel or clopidogrel, and anticoagulate them as soon as possible. For patients who are going to be treated with an invasive strategy later on in their course, you give unfractionated heparin. But for patients who are just going to be managed medically, we'll go for low molecular weight heparin like enoxaparin or fondaparinux. Now, risk stratification in NSTEMI is done mainly to identify those patients who are at high risk for further cardiac events and to identify those patients who would benefit from a more aggressive approach. So high risk patients who have a risk for further events should be managed aggressively. So we have scores like TIMI score, GRACE score. Here I'll be talking about the TIMI score. So here you have 1 point that is given for a number of criteria like age more than 65 years, presence of 3 or more risk factors for coronary artery disease, a known case of CAD with more than 50% stenosis, with a history of aspirin use in the last 7 days, history of severe angina in the last 24 hours, elevated troponin levels, and an ST deviation of more than 0.5 millimeter. These are the criteria, and a score of 0 to 2 keeps them at low risk. 3 to 4 is intermediate, and 5 to 7 are high-risk patients. Now, when should you consider invasive strategy for a patient with NSTEMI? We usually go for early reperfusion and revascularization, which doesn't have to be done emergently but done within the first 24 hours. Now, there are indications for invasive strategy that has to be done within the first 2 hours itself. What are these indications? First is hemodynamic instability or cardiogenic shock after stabilization, severe left ventricular dysfunction, persistent angina despite medical therapy, sustained ventricular arrhythmias that are not resolving with medical therapy, and presence of mechanical complications. All of these would require that the invasive strategy be done within the first 24 hours. Within the first 2 hours, I'm sorry. Now, for invasive strategy that is to be done within the first 24 hours is usually for those patients who have a TIMI score of around intermediate to high risk. So for those people, we do invasive strategy within the first 24 hours, or even for patients with an elevated GRACE risk score. So to summarize the video today, we looked at the definition of acute coronary syndrome. We went through the immediate ED management of acute chest pain with suspicion for ACS, what are the things to be done in order. Then we talked about management of STEMI, and then we subsequently went on to the management of NSTEMI. So we talked about the pharmacological aspects, we talked about the invasive strategies, and for each of these we also talked about the risk scores that we use in each of these conditions in their management. So that is with this video today. Thank you, and I hope you enjoyed it.